This patient has a nuclear cataract and also somewhat hyperopic. And of course, these patients are so thrilled because they see better than they've seen in decades when we're done.
It's truly amazing.
You're going to feel a little sting for a few seconds. So that was a little lidocaine I put in, and now the visco. That chamber's a little on the shallow side. So when chambers are shallow, in these hyperopes or anybody else, your concerns and attention has to go to a couple of areas. First and foremost, you don't want to be doing phaco up near the endothelium. You don't want to have pieces that get up near the endothelium. Irrigate nasal to temple. You're going to feel a lot of water on your eye. And you want, so I'm protecting the endothelium by using a dispersive viscoelastic copiously, right? I put a lot of viscode in there. You got to watch out for your rhexis to run out toward the periphery. And this is a convex anterior capsule, bowed forward. So it's easy for it to run out toward the periphery. And then stria in the capsule. A lot of eyes with shallow chambers have a lax zonule. So you got to be on the lookout for that too. So during the procedure, there's certain things that you probably want to do because of the anatomic situation. And we just talked about using the dispersive OVD. Okay, and here I've done a visco dissection. I'm going to do it for 360 degrees essentially, thereby creating a bit of a nuclear sandwich. Now, how do you avoid removing lens material from near the endothelium? Just checking infusion on our infusion sleeve. So, well, of course, you can keep the, I'm going to probably enlarge the side port incision here a little. Can I have a side port, please? You can do the phaco in the posterior chamber, as much of it as you're comfortable doing back there. But there's something else you can do. And that is to divide the nucleus into more smaller segments than you might normally divide them into. So that's what my plan is here. Now, if I can use little or no ultrasound to sculpt, that's a good thing. And I'm not using any here. And the patient's age.
64.
Good. Is 64. And I may not need any ultrasound. And that'd be nice in an eye with a shallow chamber. Quadrant removal.
Quadrant removal.
So far I haven't used any wet cornea. And I'm dividing the nucleus up into small sections. I'll probably wind up with 6 or 8 of them before I'm done. And just taking out another one of them. So this is our typical quadrant left here. Let's divide that. So that's an 1/8. Using 600 millimeters of vacuum, of course, is a big advantage in avoiding use of ultrasound. So there's our last nuclear, probably more like epinuclear segment. A little piece over here. And when you go sideways like this to get something, be careful, your chamber will tend to shallow. So I'm just feathering the petal off and on it, attracting that piece. All right, good. So we did the whole procedure in this shallow chambered eye without using any ultrasound whatsoever. And the endothelium is almost certainly very glad we did that. 90-degree INA tip. And remember, we still have this zonular laxity concern here, right? And I think it's real. There's some infusion, misdirection, meaning fluid go through zonular spaces. Not severe, but significant. So I'm kind of watching the posterior capsule here. It's okay, but it's not as far back as usual. And for subincisional, I want to be very careful, even though I have a 90-degree INA tip. I'm going to use this spatula and insert it. Focus up here so I can see this spot. There we go. And use it to protect the posterior capsule. Wet the cornea. So now I know my posterior capsule can't get to my INA tip, no matter what, right? Because I had the spatula tip behind it when I aspirate the superior cortex. I'm sorry, not superior, but subincisional cortex. So we're good there. Now I'm just vacuum off some of the epithelium under the anterior capsule. Good, and we're ready to put in the OVD and then the IOL. And that OVD now is hyaluronic acid. Specifically, that was Provisc. And going to tuck that trailing haptic and optic into the capsular sac before the IOL opens. Aspirate the OVD from first behind and then in front of the optic. Syringe with BSS. You can see that the rhexis was intentionally small. The reason for that being, as I mentioned, don't want to risk it running out into the periphery in an eye with a somewhat shallow chamber and a convex anterior capsule. So beware of those convex anterior capsules. You'll see them at slit lamp before you ever get to the OR. And plan them so that you can keep your rhexis from running out and expect that there may be a lax zonule in those eyes and have your plan in place to deal with that.